All right, everybody. We will finish the conversation about immunity and lymphatics. Today we'll review the quiz, and then we'll largely play it by ear in terms of the study guide review / immunity quiz. I have immunity quiz in the office, so I'm going to give it to you. We're probably going to do it in class. I mean, we'll see how we go. So, I don't include any topic on vaccine this year because largely you gotta, I don't know what to talk about. No, seriously. I mean, I cover a lot of very specific aspects of what are the different types of vaccine, how they are produced. I covered it in microbiology class, and I don't think that because it pertains more to microbial aspect of vaccine production. But in terms of the clinical aspects, vaccines are pretty simple. You just have to, use them. So what I'm trying to say, if you have any questions that you want to ask me anytime, you can ask me and I will answer them, or not if I don't know the answer, but I will try my best. Other than that, I mean, tell people to get vaccinated. That's it. I don't know what to say, really. You just got to do it. And now, here's the deal. So, if you have a question legitimately, I don't really know why is that, or what do you think about this? I'd be happy to do so. But let me be very clear. I had conversations before with people who are anti-vaccine, and I basically decided not to waste my breath on it. And if people come, if somehow I become a part of conversation about vaccines, and I try to avoid this, and there is an anti-vaxxer, my language changes it changes immediately to extremely foul language. I cannot speak normally. So, no, seriously, for multiple reasons. Anyway, we're going to be talking about the clinical syndromes associated with various immunopathologies. As you can imagine, in any system, there are two pathological options. Either the system works sort of too hard, or the system doesn't work at all. And when immune system works too hard, we refer to it as hypersensitivity. So there are 4 types of hypersensitivities. The first one is called immediate, due to the fact that it develops pretty quickly. We know this as allergy. The mechanism of allergic response is quite elegant. When you first encounter allergen, shown here as the red particles, allergen molecules are recognized by a specific clone of B cells, which undergoes clonal expansion, becoming plasma cells. But these are very specific plasma cells. These produce immunoglobulin E. This immunoglobulin enters the circulation and eventually binds to the mast cells in tissues. Now at this point, all the way up until binding, nothing happens. You don't have any allergic reaction. And then, when you encounter this same allergen second time, maybe third, maybe fourth, depends on the concentrations, allergen binds to immunoglobulin E that is already on the mast cell surface. That binding stimulates the response that we call degranulation. Degranulation means that mast cells release inflammatory mediators, mainly histamine, into the bloodstream. If the release of histamines occurs in the nose. If that allergic reaction, mast cell degranulation, occurs in the nose, you have allergic rhinitis. If it happens in the skin, you have rash, hives. If it happens in conjunctival mucosa, you have running, itchy eyes. If it happens all over the body, then you have anaphylactic shock. It's a severe allergy. So what essentially happens, histamine stimulates the constriction of bronchioles and vasodilation of virtually all blood vessels. The massive vasodilation leads to the circulatory shock. On top of that, as you remember, inflammatory response increases the permeability of the blood vessels, meaning that plasma starts to leak from blood vessels into the peripheral tissues, which significantly decreases the blood volume. So on top of the circulatory shock, the person experiences the hypovolemic shock. Does that make sense? And the only way to, well, okay, so how do you address anaphylactic shock? You give a person the analog of norepinephrine, EpiPen. Norepinephrine has opposite effects. It constricts the blood vessels, dilates the bronchioles, basically, and increases cardiac contractility and heart rate. Makes sense, right? So blood pressure is restored, respiration is restored, and then you can address sort of an underlying problem, the allergy. So questions. Can you treat an allergic response? Well, you all know yes. Right? We treat it with antihistamines. We block the action of histamine on its receptor. Okay? The previous ones, the drugs like Benadryl could cross blood-brain barrier, enter the brain, and affect histamine function. And histamine plays an important role in regulating sleep-wake cycles. That's why Benadryl is so good to, use. It's not good. It's not really a sleeping aid, but as any pediatrician will tell you, if you're going to fly somewhere, a teaspoon of Benadryl will not hurt your child, and you will have much easier flight. Now, the modern versions of antihistamines, anti-allergy antihistamines like Zyrtec or Claritin, they do not cross blood-brain barrier and act very specifically on the epithelial cells. Now, there are some drugs like cromolyn that inhibit degranulation. They're not used widely, because they will be effective in case of acute, immediately during the allergic response. In case of long-term severe allergic response, basically what you need to fight off is the inflammation. So anything that depresses the immune response, such as steroids, corticosteroids would work. Can be applied topically if it's allergic eczema, or sometimes they have to be taken orally if it's a severe allergic reaction, systemic allergic reaction. Now here we come to the most interesting story. Can we cure allergy? Actually, we can. Not all of them. But you can cure, for instance, weak allergies like a pollen allergy or cat allergy. And I have cat allergy. And I would not call it weak. Okay? But those can be cured. And the cure is counterintuitive. You cure an allergy with allergen. What you essentially do, you expose the patient with an allergy to the small amounts of an allergen in the controlled settings. This is called desensitization. You may have sensitization. So essentially, you train the immune system to stop recognizing the allergen. This largely empirical approach, bless you, works. You can get desensitized. Okay? The downside is that it may take up to 2 years. You visit doctor every so often and you receive the dose of allergen. Alright? Technically, you can do desensitization in the home settings. My wife suggested that we would have a cat, and I know that if we would have a cat, I would have an allergic reaction, and most likely it will be gone in 3-4 weeks. But knowing how I respond to cats, and especially how my son responds to cats, said either me or cat. Because I'm not willing to take Claritin and if you take Claritin for 4 months, desensitization may not really work, because it affects the immune responses as well. That makes sense? Now, obviously, allergies, I believe people in this room have allergies. I speak from my own perspective, okay? So my cat allergy is bad. It's not terrible. So I either take a Zyrtec before I go to house that has a cat, or if I don't know and that happens, usually I'm fine. If I'm not spending a night at the house. So like if I'm visiting friends and they have a cat, as long as I'm not touching a cat and I'm careful in touching my face, I'm fine. Okay? Obviously, the allergy that is kind of an elephant in the room is peanut allergy. Severe, there are tables specifically for people with peanut allergies that nobody else can see it, like all that kind of avoidance practice that protects them from having anaphylactic shock, even from the trace amounts of peanut allergens. And this desensitization approach actually works. Not curing, but reducing the severity of the response. In one clinical study, people with peanut allergy, extremely severe, at the level of I'm not sitting next to a person who is eating peanut butter sandwich, like that level, they were given very, very small doses of the peanut allergen, some protein they isolated, okay? And after, I believe, several months of treatment, the threshold of allergic response increased dramatically. So basically, they now can sit next to a person who's eating peanut butter without having anaphylactic shock, having any response whatsoever, actually. Does that make sense? So desensitization works, but conceptually, yes, it can cure. Practically, years. So many people would not take that commitment. What makes you allergic to something? Nobody knows. Seriously. Like, I became allergic to cats at the age of 9. I was totally fine before that. Since then, I'm allergic to cats. Okay. So my son's allergic to cats from very beginning. Like, first time I was exposed to a cat, he got an allergic reaction. So probably some genetic factor that was activated in me at some point, and he just got it in all blown up, activated form. I don't know what. Maybe some epigenetic regulation, I don't know. But peanut allergy, we have a glimpse of how you can kind of reduce the risk of allergic responses in your children. You know the recommendation that many pediatrician, neonatologists, or OBGYN doctors will tell a mother, don't eat peanut butter because it will make your child allergic to peanut butter. Don't eat strawberries because your child will be allergic to strawberries. To test, and interestingly enough, that this claim had absolutely zero evidence to it. It was sort of an opinion. So there was a study, several studies actually. The most comprehensive was done in Israel. They looked at the population of pregnant women, and they were deliberately eating peanut butter, and some weren't, just because they probably didn't like it. Okay, and then they compared the population of women who ate peanut butter and the rate of peanut butter allergy in their children to the population of peanut butter free women, basically, and the rate of peanut allergy in their kids. And it turns out that eating peanut butter during pregnancy reduces the risk of peanut butter allergy in kids by about 90%, which is a lot, as you can imagine. From a immunological standpoint, it makes perfect sense, because when you expose an immune system, the fetal immune system, to an allergen during its development, it is likely that fetal immune system will perceive that allergen as something normal, something that belongs to the overall complex of pregnant mother and the fetus. Does that make sense? So this recommendation was shattered by the evidence-based medicine. Does that make sense? Now, type 2 hypersensitivity is the story about blood and blood types. So in this case, type 2 hypersensitivity is mediated not by IgE, but specifically by IgG, immunoglobulin G, with all consequences that we will discuss in a minute. So essentially, in type 2 hypersensitivity, immunoglobulin G recognizes antigen that it shouldn't. And the best example is transfusion reactions. I know that some of you are pretty familiar with blood types, some of you aren't. I'll just remind everybody. So these are red blood cells, and on their surface they carry carbohydrates, so-called agglutinogens. Okay? Agglutinogen A and or agglutinogen B. Which agglutinogen is expressed on the surface of red blood cell is determined by the genome of a person. And it's a great example of non-Mendelian inheritance. When the person can inherit the A allele, basically the gene for A, the gene for B, or may inherit no functional AB genes. If the person inherits two alleles that are neither A nor B, blood type O. If the person inherits only A, blood type A. If the person inherits blood type allele B, blood type B. And some people inherit both A and B, which makes them AB blood type. We're not in the genetics class, so I'm not going to break down the whole different versions of which blood types of parents will give a certain blood type to children. What I want to focus your attention on, again, is that in the person, these red blood cells may have either one of those, or both, or neither. Is that clear? That's agglutinogens. They antigens. Now, those agglutinogens present in the red blood cells. Agglutinins, antibodies against either A or B, are present in the plasma. And agglutinogens and agglutinins are mutually exclusive. What does that mean? It means that the person who has blood type A doesn't have the anti-A antibodies. Does that make sense? Do I understand? They're mutually exclusive. The person that has a blood type B does not have anti-B antibodies. The person who has blood type AB has no agglutinins at all in the plasma. In the plasma, remember, in the plasma. And the person with type O blood type has both A and B agglutinins. Am I clear? Good? Cool? So, what are the outcomes of this? in terms of the clinical perspective. So if you transfuse a blood which contains, say, red blood cells with agglutinogen A, so type A red blood cells, into any recipient that has anti-A antibodies, anti-A antibodies will bind to A antigen, and those antibodies will agglutinate red blood cells, and you're going to have transfusion reaction. Does that make sense? So if you transfuse the blood type with, say, agglutinogen A into a person that has agglutinin anti-A, red blood cells will be agglutinated by anti-A, will form a clump, and that's a transfusion reaction. That makes sense? Now, let's think about it again from the clinical perspective, from the clinical perspective. So, when blood is transfused, real blood is transfused, which component is sort of most important? RBCs, red blood cells. The amount of plasma that is transfused is really low. Does that make sense? So, when you transfuse those red blood cells, you basically need to take, the main thing that you need to take into account, which agglutinogens, which blood type, which agglutinogens are on the donor's blood, and which agglutinins are present in the recipient's blood. So let's say a recipient has AB blood type. So recipient red blood cells have both antigens. Does the recipient have any antibodies? No. Meaning that what blood type this recipient can receive? A, B, AB, or O, right? Any. So the person with blood type AB is essentially a universal recipient. Does that make sense? Now, what if the person that receives the blood is a blood type O? Which agglutinins are present in this person's plasma? A and B. Meaning that what's going to happen if the person with blood type O receives the type A blood? Reaction, because anti-A antibodies will react with A agglutinogen. Does that make sense? What if this person receives type B red blood cells? Reaction. Well, if type AB, definitely reaction. Does that make sense? However, if you think about it, red blood cells from the person with blood type O without any agglutinogens, those red blood cells are red blood cells of a universal donor. So if you have type O blood, that makes you a universal donor. And if you have type AB blood, it makes you a universal recipient. Does that make sense? So for the exam, what you need to understand is, like, the person with such and such blood type can receive such and such blood type. Am I clear? Good. Now, what constitutes transfusion reactions? They're pretty bad. Hemolysis followed by anemia and hypoxia, and hemolysis always leads to kidney toxicity. So transfusion reactions can be pretty severe. In fact, blood types were discovered by Karl Landsteiner, and if my memory serves me well, in about 1912. Meaning that, well, before that, the attempts to do the blood transfusion were still done. You know, people were still transfusing blood. And as one physician in, I believe, the 19th century put it out, said that for blood transfusion, and in some cases, doctors try to transfuse animal blood. Well, because human blood, we talked about. Collection of human blood, it's going to clot. Make sense? So you need some clotting inhibitor, and I don't think heparin was abundant then. Okay? So you need direct transfusion, and it's a problem because the donor got to get the artery cannulated, you know. It's a bit of an issue, you know, poking somebody's artery. So animals were obvious choice. And as this physician said, for blood transfusion you need 3 sheeps. A doctor, a patient, and an actual sheep, where the blood is drawn from. They tried blood transfusion from sheep, from cows, from monkeys. Never worked, so you can imagine. Now, these 2 antigens that form 4 blood groups obviously aren't the ones. In fact, as far as I know, there are something like 200 different blood types because of multiple groups of blood antigens. Does that make sense? So there are many surface markers on the red blood cells. But these 4 blood types are of the main clinical concern. Another blood type, well, blood antigen, that is also really important is the rhesus antigen. You've heard about it. It's called rhesus, or sometimes called D antigen. Now follow me. There are people who are rhesus positive, and there are people who are rhesus negative. I can be an example of only one group, so I can tell you I'm O, rhesus positive. Anyone rhesus negative here? Okay, rhesus negative. May I use just to illustrate? So I have antigen on my red blood cells, Rh antigen. Does that make sense? Meaning that I don't have antibodies. Is that clear? Now, Alexandra doesn't have antigen, Rh antigen, on her red blood cells. But interestingly enough, in case of Rh, she doesn't have antibodies. So if you don't have Rh antigen, antibodies are not preformed at birth. No, you don't have antibodies. Does that make sense? So you only have or don't have an antigen. Now, why it is important? Imagine for a second that my O rhesus positive blood is transfused to Alexandra. She normally doesn't have Rh antigen. Does that make sense? Her immune system doesn't know about this antigen existence. And here come my red blood cells. Immune system recognizes Rh antigen as something foreign and starts to produce antibodies to it. Does that make sense? And after that transfusion, she will have antibodies to Rh, and that will limit the options. You know, you can only receive Rh negative blood since then. Does that make sense? Now, you know, that mismatch is also taken into account, and it plays the difference in presence or absence of Rh plays a crucial role during pregnancy. What is called a rhesus conflict. Now let's break it down. So in rhesus conflict, mother is Rh negative. She does not have rhesus antigen on her red blood cells. And baby, the fetus, is Rh positive. You with me so far? Now during pregnancy, do mother blood and fetal blood, do they come into direct contact? They don't. So there's no immune exposure, everybody's safe, everything's good. And then delivery happens, and during the delivery, that's when mother's blood comes in contact with baby's blood, when placenta is separated. Does that make sense? And babies' Rh positive red blood cells enter into mother's circulation. Mother's immune system recognizes baby's Rh plus cells as foreign and forms antibodies against them. At this moment, where's baby? Where's baby? Huh? Come on. Outside somewhere, I know. Mom's holding baby in her hands or something. Not in the womb. So these antibodies, they don't do anything to baby, right? First, baby's safe. Got it? And then the same rhesus negative mother, who now has antibodies against Rh, gets pregnant again. And the fetus is Rh positive again. Following me? And these antibodies, bless you, will cross the placenta because they are immunoglobulin G, they can do it. They will cross the placenta, they will bind to the fetal red blood cells and will cause a disease that's called hemolytic disease of newborns, or erythroblastosis vitalis. Okay? Red blood cells will start to get destroyed in the fetus, in the womb. So we're talking about hemolysis, hypoxia, kidney toxicity, and all the same. So it's basically a kind of transfusion reaction, but in the fetus and in the womb. Really severe condition, treated with blood transfusions, really severe. Now, the question is, can we somehow avoid this? The answer is yes. We have a magnificent approach, which is called ROGAM shot. Those are, interestingly enough and kind of surprisingly, antibodies against rhesus factor. Does that make sense? These antibodies cannot cross the placenta. They can't. You following me? So what happens? During first pregnancy, mother receives a ROGAM shot. And now, before the delivery, she already has the circulating anti-Rh antibodies. Does that make sense? The moment fetal red blood cells enter into mother's circulation, those recombinant ROGAM anti-Rh antibodies bind to the fetal red blood cells, efficiently masking them from mother's immune response. Does that make sense? They form a cloak. You see what I'm saying? If all Rh antigens are already bound by those artificial antibodies, immune system will just not see them. Okay, it's absolutely genius solution, and it allows women with rhesus conflict, with multiple pregnancies, without any health consequences to a fetus. Does that make sense? You will get a question on the exam about the rhesus conflict and the mechanism of rhesus conflict. Probably one. But it's going to be exactly about mechanism. So understand who's positive, who's negative, what happens, how it is prevented. Does that make sense? Any questions? This brings us to the third type of hypersensitivity. Type 3, that's your true hardcore autoimmune disease. Antibodies, that's mediated by antibodies. Antibodies are produced against your own antigens, most frequently antigens found in the basement membrane. Now, basement membrane separates what? AP1 course, approximately third lecture, maybe second. Tissues. Separates two types of tissues always. One of them is pictured there. Basement membrane separates epithelium and connective. Basement membrane is at the basal side of any epithelial layer. Does that make sense? So, antibodies that target proteins in the basement membrane, well, get in the basement membrane and form what we call an immune complex. Now, this immune complex will be recognized by macrophages and neutrophils. Those two cell types. What is the common mechanism that they have in terms of, destroying stuff? They have phagocytic cells. Does that make sense? So macrophages and neutrophils will try to get rid of those immune complexes by destroying them, leading to basically destruction of the basement membrane. They will also release a bunch of inflammatory cytokines, activate complement. Okay, it will all lead to a massive inflammation in basement membranes. Now, basement membranes, as we mentioned, separate epithelium and connective tissue. So, where can we find epithelium? This is an epithelium in the blood vessel, basically endothelial cells. You're going to have an inflammation of endothelium that we call vasculitis. If it's in the heart, endothelial inflammation in the heart is called endocarditis. Inflammation of endothelium in the joints, the synovial membrane, is called synoviitis and eventually arthritis. Inflammation of the basement membrane in the skin is psoriasis. And inflammation of the epithelium of glomeruli, in the kidneys is glomerulonephritis. Now, obviously it's not like all of it is targeted because proteins are different in different basement membranes. But, for instance, in the condition known as systemic lupus erythematosus, or lupus, main organs that are affected are blood vessels and kidneys. That's sort of a first manifestation. It can be more, they can be endocarditic symptoms, they can be skin symptoms, but vasculitis and increased frequency of thrombotic events is pretty frequent. Another example of disease that has a type 3 hypersensitivity component is rheumatoid arthritis. Antibodies that target the synovial membrane will lead to arthritic inflammation. There's no cure. Treatment includes immunosuppressants. Corticosteroids are pretty frequent. Now we have some drugs that are more targeted against certain inflammatory molecules. Okay, you may have heard the name, I don't know if it's a brand name or generic, Remicade. Probably generic. It's the drug that targets tumor necrosis factor alpha or TNF alpha. So it just decreases the inflammatory response. Pretty effective drugs and pretty nasty side effects, but nevertheless. Okay, so that's true autoimmune disease. Now, type 4 hypersensitivity can be both. So let me, before we talk about the mechanism, I want to mention that different diseases, autoimmune diseases, they usually have multiple components. Does that make sense to you, that statement? So say in lupus, the main component is type 3 hypersensitivity. In rheumatoid arthritis, mainly type 3 and type 4. In multiple sclerosis, type 3 and type 4. Does that make sense? So it's multi-component diseases. Now let's talk about the mechanism of type 4 hypersensitivity that is also called delayed. It is delayed because it's mediated not by the humoral branch of adaptive immune response, by, not antibodies. It's mediated by cells, by T cells. So what essentially happens? You get exposed to an antigen of sorts, okay? It can be a protein, sometimes it can be even a haptene, but you get exposed to the antigen, which is recognized by a dendritic cell, which presents this antigen to CD4 T cell, the T helper cell. And T helper cell, in response to that antigen, activates macrophage and CD8 T cell responses. Now remind me please, what is the main function of macrophage? In one word. Kill by phagocytosis, right? What is the function of CD8 cell? Kill. Cytotoxic lymphocyte, the killer T cell. So they both are killing cells, cytotoxic cells. Does that make sense? By the way, usually upon the first exposure, nothing really happens in terms of the clinical presentation. That's when the immune response is formed. And then the patient gets exposed to that same antigen second time. Now this time, presentation of antigen to a memory cell will lead to activation of macrophages and CTLs, and they will start to attack the antigen. But antigen is not like just hanging in an empty space. So when I say attack the antigen, I essentially mean attack the tissue where antigen is. Now, what are the examples? One great example is TB test. If you ever were exposed to tuberculosis, either in the form of a vaccine or actual infection, well, vaccine is maybe yes, maybe no, but if you ever had TB infection, your immune system at some point produced very specific CD4 T helper cells, memory cells. Does that make sense? So when you go for a TB test, the intradermal needle delivers the antigen from Mycobacterium tuberculosis into your skin, where Langerhans cells present that, those are dendritic cells. They present this antigen to memory helper cells, and those memory helper cells start to expand and activate macrophages, specific macrophages, and cytotoxic lymphocytes. Macrophages, cytotoxic lymphocytes try to get rid of the antigen that is in your skin. Cytotoxic response leads to the local inflammation, bump, TB reaction. Does that make sense? Got it? Questions?
I'm just wondering about, I don't think it's this type, but there, I don't know how to word it. Okay, I've been stung by bees before,
Mm-hmm.
and I have a reaction that's not normal.
Yeah.
And then I went to the doctor and they said, well, you need to have an EpiPen because if you have, if it happens again, your reaction can get worse.
Uh-huh.
So I'm kind of confused because, how you said the more you're exposed to something, the less allergic you will have. Is it more on a regular basis?
Yes,
Okay.
that's one. On the regular basis and in controlled settings. Because you can basically go to a beehive and let bees bite you, hoping that it'll cure your allergy. What most likely is going to happen, you're going to die. It's basically, this is why we do this in the controlled settings. Because you can never predict the outcome of a particular reaction. So your reaction to a single bee bite, bee sting, can be mild or can be really severe. EpiPen, therefore. It's type 1 hypersensitivity. Okay? What's type 4 is the poison ivy. The first exposure to poison ivy, you don't notice it. You don't know. Because that's during the first exposure, your immune system produces this cytotoxic cells. It's the second exposure that gives you this terrible skin reaction. Does that make sense? Okay. Question, Casey.
I was going to ask what are two examples of it. You said poison ivy is one.
Poison ivy TB test. Yeah. And speaking of reactions, yeah, reactions can differ. My cat allergy depends on the cat. I spent hours in the close proximity of certain cats. I don't know what breeds they are. And then I vividly remember my friend and I would walk in the apartment, just do something. I don't know. Like 10 minutes later, I say, I bail out. I cannot, and I was standing in the hall, not touching anything. They just had a cat in the house. I didn't even see the cat. I say, see you later. I'm going to go suffer outside. Just runny nose, swollen eyes, cough, everything, you know. So it depends on, probably it's going to depend on which bee stings you, what this bee has on the sting. Multifactorial response. That make sense? If you want, during the break, I can tell you how to trick the TB test. There's a way to get around it. I had to do it because I'm vaccinated against tuberculosis. And if my TB test comes positive, that's the whole hassle. And I know in Russia there's a program of detection of tuberculosis in children. Like through the entire school, every year I must to get a chest X-ray to confirm that I have no clinical tuberculosis. Okay, so I knew I didn't have clinical tuberculosis. Anyway, couple more things about immunity. Transplantation. Autograft is the self-graft. Most common example is transplantation of a skin on the site of a bird. Okay? Isograft. Transplantation between two identical twins. Identical. Remember, they're identical or homozygous, and fraternal or heterozygous. Fraternal twins are just like any other brother and sister, brother and brother, sister and sister. Does that make sense? So if you have a twin, identical twin, it's a good time to lock this person in the basement and use as a future organ donor. Do it first, because they can think about the same now. Allograft. Transplantation between unrelated people. By unrelated, I mean mother and daughter, brothers, father and son, father and daughter. Any relatives that are not identical are unrelated immunologically. Does that make sense? There are situations when you have a mother who needs a kidney and a daughter that's willing to give it, but they are so mismatched immunologically by the MHCs that there's no way they can serve as a donor and recipient. Does that make sense? And finally, xenografts from an animal to a person. Rare. Mostly poorly vascularized tissues like ligaments, tendons, cardiac valves. Make sense? Now, what are the two problems? First problem is the rejection. This is the case of the solid transplantation. So say somebody receives, as we mentioned, kidney transplant. So when kidney is transplanted into the recipient's body, recipient's immune system will recognize transplanted kidney as the foreign cells, because MHC molecules on transplanted kidney are different from MHC molecules on the recipient cells. Does that make sense? And the host's body, host's immune system will mount a cytotoxic response against the transplant, and that's it. Transplant will become inflamed, will be rejected. Okay? I mean, when rejection, please, rejection is not like, there's some tiny little hands that just push it away. No, rejection is inflammatory response to transplantation. For instance, one of the main problems associated with kidney transplantation, just general inflammation in the kidney, and moreover, inflammation in the blood vessel that leads to the kidney in the renal artery. If renal artery stenosis becomes narrow, transplanted kidney will go into hypoxia and will die. Make sense? So to avoid rejection, people take immunosuppressives. And basically, the success of transplantation depends on how closely people are matched and how effective immunosuppressive therapy is. Okay? And yeah, people have to live on immunosuppressants for the rest of their lives. There are approaches trying to make organs more compatible, but those are more experimental approaches. My personal take, there are inducible pluripotent stem cells, when basically it means that scientists can take cells, regular cells from you, and return them back in time, making them stem cells again. And then from these stem cells, they can grow an organ. And it was done in the lab, in the research settings, and I really think that it's probably going to be the deal in, I don't know, a decade or something, when in case somebody has a failing liver or failing kidney, those failing livers or kidneys will be individually grown in the lab, overcoming any possible complications, such as rejections. Yes.
So do you have to take anti-rejection
immunosuppressants?
Yeah, do you have to take those even if you are getting something from somebody who's like your identical twin?
No, identical twin should be fine. Yeah. But don't again, it's the term, the question is how matched they are. And it's interesting that in case of transplantation, it is often not the recipient that selects which donor to take, but the other way around. Because there are a lot of people on the list of potential recipients, people who need transplant. But transplants come and go, like I'm an organ donor, and there are a lot of organ donors, and say an organ donor dies in a car crash, okay? So these people that person can now be a donor of a kidney. But that kidney of that particular person will match only certain recipients. And that's a selection process is quite complicated. There was a case when the donor and recipient were across the pond. Across the Atlantic Ocean. I don't remember who was where, but the deal is that the donor organ was transported across the pond by a military jet, because that was the fastest way to get it. Okay, because it would take too long. Okay. Another problem associated with transplantation, specifically transplantation of a bone marrow, is so-called graft versus host disease. Now, when bone marrow is transplanted in case of leukemia, what should happen to recipient's bone marrow first? It has to be destroyed, exactly. It has to be obliterated, okay? And radiation is used for it, okay? So radiation obliterates the person's own bone marrow. And then donor bone marrow is introduced, okay? By the way, you can get on the bone marrow donor list. It's free, basically effortless. Do it. So the person donates bone marrow. You don't have to die for it. Okay, they just take a draw. And then this bone marrow goes into the recipient, which, remember, has no own immunity. Bone marrow is completely obliterated. Are you with me? So new bone marrow comes in, looks around, well, comes in, starts to produce white blood cells, including dendritic cells, T cells, and B cells. And these dendritic cells, antigen-presenting cells, they like look around, say, holy cow, all those tissues are foreign. Remember, they come from a different person, right? And they start to destroy the foreign tissues. They start to destroy their new home, the new body that they were transplanted into. Does that make sense? This is called graft versus host disease. That's the situation when the donor bone marrow attacks the recipient's tissues. You see, in rejection, recipient's immune system attacks the graft, the transplant. In graft versus host disease, the immune system that is derived from the grafted bone marrow attacks the rest of the recipient tissues. Also, immunosuppressants have to be taken and said, okay, like lifetime. And it's more common. Go ahead.
I was going to say, have you ever heard of stem cell immunotherapy?
Yes.
Okay, I don't really know how that works, but like my aunt
I can tell.
she's getting that treatment.
Yes. So, yes, of course. Of course. The idea is that if you can get stem cells and proliferate them into... Does she get her stem cells? So, yeah. You get your stem cells. They are... Stem cells can become practically anything, right? So they take these stem cells and force them to proliferate and differentiate into normal bone marrow. And then they transplant her bone marrow, not without quotation marks, her new bone marrow instead of the failing old one. Make sense? That's like really easy. Okay? That's stem cell immunotherapy. Another therapy specifically, oh yeah, we talked about it, the chronic lymphoblastic leukemia, the CAR-T therapy, the CAR-T cell therapy. No? So that's pretty elegant. Say you have B-cell lymphoma, B-cell leukemia. Okay, your B cells are proliferating like crazy. Instead of receiving a bone marrow transplant, doctors can take T cells from you, following me, T cells, and transform them in such way that this new transformed so-called chimeric T cell will attack your B cell. Does that make sense to you? So T cells become targeted against your B cells. And remember, you have B cell problem. So when these T cells are injected back into you, these T cells will eliminate all your Bs. So yeah, you're going to lose humoral branch. It's going to be kind of not good, but your lymphoma will be gone. It's called, again, CAR-T immunotherapy. You can look it up. I don't remember if I don't think they dealt the Nobel Prize for it yet. I believe they're going to do it. Works better than actually can expect. Recently, FDA approved it for, it was initially approved for adults, now it is approved for children. So it works, and it turns out people on CAR-T cell therapy, they have really good remission rates. The immune system is not impaired that much by the lack of B cells. Okay? The only problem is that the treatment, initial cost of treatment was $450, $1,000. Now it went down to $300,000, which is still a lot of money. And it is possible that it has to be repeated later.
So I know someone that had transfusion or
Bone marrow transplant?
no, like an organ.
Organ transplant,
Yeah.
solid organ
And
transplant,
he
yes.
is on the immunosuppressant,
Mhm.
and he also he can't be around sick people.
Of course.
He really tries not to.
Absolutely.
So that
impaired, absolutely, forever. The person is immunosuppressed for the rest of their lives. I have now a student in my micro class who is on immunosuppressants. And the student warned me the very first day saying, well, I cannot, shield her from other students, but at least I can tell, okay, don't work with this microorganism, that's kind of a bit higher level of threat. My wife worked with a guy who was in remission after leukemia treatment, and if somebody sneezed in the lab, she said, "I'm out." He never ate. He prefers not to eat at the public places because he can't trust. He cooks the food himself. Okay. No, he's fine. Like but he's on immunosuppressants. Now, basically, the last thing to talk about immunity is not when the immune system is too active. It's when it is not too active. So immunodeficiencies. There are two types: congenital and acquired. Acquired immunodeficiency is, say, cancer. People don't have cancer, then they develop cancer, that's acquired. AIDS is an example of acquired immunodeficiency. Technically speaking, any immunosuppressive treatment is acquired immunodeficiency. Does that make sense? Severe disease is acquired immunodeficiency. Severe stress leads to acquired immunodeficiency. The point is, you are not born with that immunodeficiency. Does that make sense? Now, what is congenital? First of all, if you look at this flow chart, you will see that this congenital the chart addresses only adaptive immunodeficiencies, right? Adaptive response, T cell or B cell response. Now, can it be innate? Brief answer is yes. Can it affect the well-being of a person? The brief answer is yes. Obviously, there are longer answers, but think about why deficiencies in the innate responses are less influential than deficiencies in adaptive. What's the difference between adaptive response and innate response? What are the differences? Fast and what? What about efficiency? It's not super efficient. And what about distribution in the body? It is, well, local. Innate responses are local. They're local and not super efficient. So if innate responses are not working properly, it's not going to affect the response to infection that much. Does that make sense? I mean, there are situations, there are people who are genetically predisposed to more severe influenza infections due to the innate deficiencies. It is known. Clear? But that's like really, really, really spot here, spot there, group here, group there. Congenital immunodeficiencies associated with adaptive response can be broken into two large groups. One group is T cell deficiencies. Basically, it's a DiGeorge syndrome. DiGeorge syndrome is not only immunodeficiency, it's also developmental disability, mental and motor. But in DiGeorge syndrome, the person does not produce mature T cells. So, really high sensitivity to viral and protozoan infections. In the B cell immunity, bless you. In the B cell immunodeficiency, called agammaglobulinemia, the person does not produce mature B cells, therefore does not produce antibodies. So, main concern are bacterial infections. There are various forms of hypogammaglobulinemia when levels of B cells are lower. Does that make sense? And then there's SCID. Or X-linked, severe combined immunodeficiency. And a person lacks the adaptive branch of immunity altogether. Does that make sense? No B, no T cell responses. Have you heard about boy in a bubble? That's that. So the person has no adaptive immunity. The person has to receive sterilized food. All medical personnel and all relatives have to wear protective equipment to prevent the transmission of any type of even the most benign microorganism to a person, because everything can be lethal. And the treatment is, well, bone marrow transplant is ideal. But there was a case of a patient who actually started a regimen of blood transfusions and ended up living independently, receiving blood transfusions, meaning, white blood cells, immunoglobulins from healthy people, and it was pretty good. But this person died in the early 30s of his age because of the kidney failure. Every blood transfusion, no matter what, is associated with some hemolysis. It's going to happen because we match blood group, but there are many more, like A, B, but there are many more blood types, and those reactions can lead to transfusion reactions. Transfusion reactions lead to hemolysis. Hemolysis leads to kidney toxicity. Does that make sense? The second case, the kid received the bone marrow from his sister. And the bone marrow was, now why it's called X-linked? Because, that's the male, and that's the female, right? So if there is an anomalous gene that I labeled blue and it's recessive, right? You see the blue dot? That's recessive anomalous allele. So if male inherits it, like this, then this male, since its allele is recessive and there is no, that arm of the Y chromosome is absent, so this recessive allele will get expressed, the person is going to have, the male is going to have SCID. If a female inherits it, then there's, in this arm of the chromosome, there's a dominant allele. Dominant allele trumps the expression of the recessive anomalous allele. Woman is just a carrier. Make sense? So it's male disease. And this boy received a bone marrow transplant from his sister. Nobody knew that his sister had latent Epstein-Barr virus infection. You know it as mononucleosis. And the kid, who had absolutely no immunity whatsoever, developed systemic Epstein-Barr infection and died. Actually, this family ended up having 2 more kids. Second one had SCID and died at the age of 6 months. And the third one, luckily, had this combination of alleles. Does that make sense? And was totally healthy. But that's basically a male disease. That make sense? So here the only thing I'm gonna what is SCID? What is agammaglobulinemia? Which arm is affected? What is the T cell associated problem? And you have to be able to tell apart acquired and congenital. Does that make sense? I give you a list of immunodeficiencies. You tell me which one is acquired or which one is congenital. Questions? If there are no questions, we're going to take a break. Oh, yeah, hold on. Yes. It's T cell responses, cellular adaptive responses. So we're going to take a break, and we'll come back. We'll review